So I'm going to talk mostly about obesity management. I want to start by saying that I think that the obesity epidemic is an unintended consequences of economic, social, and technological changes in our society and really around the world. That food supply is low in cost, it's very abundant, it's very palatable, and it's very high in caloric density. And labor-saving technologies have virtually eliminated requirements for physical activity as a part of everyday life. So we're eating more and we're exercising less, and the net effect is this. This is our dilemma. I think it's very large in the US, but it's growing around the world. The increase in the average weight of the population. And that occurs throughout the world, and here you have prevalence data of overweight and obesity from Canada, Spain, US, England, Italy, France, Austria, and Australia. You can see that the lines are pretty parallel, and everybody since the 1970s has been going on around the world. And of course, this translates not only to comorbidities related to this, but particularly to diabetes and the growth of diabetes around the world. There is an interaction between genetics and environment, and I'm showing you this picture of a population group with a group of that population who are genetically predisposed, that is, they have a propensity to already gain weight. And if they're subject to adverse environmental conditions like the ones I've just described to you, then they have the clinically affected phenotype and they become overweight and obese. And in fact, I think this is what's happening around the world. You can see that from the Pima Indians. These are Indians in Arizona on the left and Indians in Mexico on the right, genetically identical groups. The Arizona Pimas live in the reservation south of Phoenix. They drive pickup trucks, they drink a lot of alcohol, they eat a lot of high-fat foods that are given to them by our own Department of Agriculture. All the excess cheese and butter goes to the Pimas in Arizona. And these Pimas are working hard, they're farmers. They live in the hills, they do a lot of physical activity. They eat a much lower fat diet, a much higher high fiber carbohydrate diet. And you can see in men and women the weight of the Pima Indians in Mexico and the Pima Indians in Arizona. So clearly, a certain group in the population, and a large group, is at risk, and when the environment changes and the environment goes to one with a lot of food, a lot of cheap food, very little physical activity, you get this situation. So you've seen this before. Our problem is that we're eating too much and we're exercising too little, and we tip the balance towards excess weight. So the treatment pyramid is like this, with lifestyle behavior change on the bottom, and of course we're talking with what you eat and how you move around. And then there's pharmacotherapy, for which there has been very little until very recently, and a lot of the drugs for obesity have had enormous side effects, which have meant that they've come and gone. So there's been a real problematic situation with appropriate drugs that would not be that were not unsafe for the individuals who were using it. And then finally, surgery, which has come of age in the last decade, of which you just heard. Now, this is the guide for selecting treatment. These are the NIH guidelines, and they're now really a little old, but they were published in 1998. And you can see here the BMI 25 to 27, 27 to 30, 30 to 35, 35 to 40, and greater than 40. And the idea is that one should do or try to do behavior modification, improve diet, increase physical activity in all of these people. Pharmacotherapy was considered okay in people who had a BMI over 27 and had comorbidities. And then weight loss surgery in people above 35 who had comorbidities and over 40 who did not have comorbidities. Well, we've come quite a way since 1998, and I show you this article by Ed Livingston, who's one of the associate editors of JAMA, in which he editorialized about the inadequacy of BMI as an indicator of bariatric surgery. That BMI is not really a great tool for figuring out what you're going to do for a particular individual. And he states, although weight loss in general is desirable for obese patients, the overweight condition by itself is not informative. Physicians need to know an individual patient's risk factor profile before initiating surgery. Here's an example of what we're talking about BMI. This is a study that Dr. Gallagher in our center published some years ago, and it gives you the BMI here from 15 up to 50, and the body fat and percentage measured by underwater weighing, which is the best way to measure body fat. And you can see the enormous range. These are men here, these are women. As you know, women have about double the fat in their body for the same BMI. Men and women are really different with regard to adipose tissue. But you can see the enormous range. Take somebody who's got a BMI of 30, they could have a body fat of 10% or a body fat of 40%. And so there's a wide range within the same BMI in individuals. And that is one of the problems with using BMI as our threshold and our cutoff points for treating diabetic patients, treating obese patients. Here's an example of this. This is an article that was published a couple of years, some years ago, and these are two individuals who have the same BMI, 22.3. This gentleman is a doctor in the UK who's European. This is a South Asian, also living in the UK. And here's the body fat. This fellow has a body fat of 9.1%. This fellow has a body fat of 21.2%. So BMI, as you can see, will not really do very well in individuals reflecting the amount of fat that they have in the body. So we have to go to the risk factors, and there are a lot of risk factors. And so when you see an obese patient, you have to ask, obviously the eyeball test is good enough to tell you that they're overweight or obese. You can do their BMI, I think it's worth doing. But then you have to go to the risk factors, and of course they're enormous. And the biggest ones really relate to diabetes and coronary heart disease, diabetes, dyslipidemia, hypertension. However, along with the cardiovascular disease, there's also cerebrovascular disease. There is a growing recognition that obesity is related to a number of cancers. The causation is not exactly clear, but certainly breast, uterus, cervix, colon, esophagus, pancreas, kidney, and prostate are higher. The prevalence is higher in obese people than it is in lean people. Then there's all the gynecological abnormality, gallbladder disease, non-alcoholic alcoholic fatty liver disease, pulmonary disease, and obstructive sleep apnea. So there is a whole host of risk factors that one has to look at. And obviously, the more medical complications your obese patient has, the more you should consider active intervention with behavior change in that individual patient, because as weight loss occurs, these risk factors get better. we want to reduce fat in the body. And there's an emerging concept that the localization of fat determines health risk. So if fat accumulates in tissues other than the subcutaneous adipose tissue, it's deleterious for insulin action and predisposes to diabetes and cardiovascular disease. So the thought is that subcutaneous adipose tissue is actually protective. And as long as you can put fat in the subcutaneous tissue, you're okay. Your chances are your risk factors aren't going to be that high. But when you start overwhelming the subcutaneous tissue and begin to put fat in other places, you run into trouble very rapidly. And the other places are the visceral fat, intra-abdominal fat, into muscle, into liver, into the beta cell of the pancreas, into the heart, and into the vascular system. And as you do that, you build up all of these risk factors that lead to morbidity and mortality in obese people. So you develop a lipotoxic state that affects the liver, the muscle, the visceral fat, the heart, and beta cells. I can't go into the whole pathophysiology, but it lowers glucose uptake, and it increases free fatty acid release, and it increases adipokines release, because we know now that the adipose tissue is an endocrine cell. The adipose cell is an endocrine cell. It puts out a whole host of cytokines that are actually detrimental to health. TNF-alpha and IL-6 enhance inflammation in the body. Plasminogen activator inhibitor enhances clotting in the body. Angiotensinogen enhances blood pressure in the body. And so these cytokines that are released from adipose tissue are important in the health risks that occur. So what are the weight treatment goals? Well, in the old days, people took very low-calorie diets, and they started here, and they went down all the way to here, and theoretically they were going to be normalized and stay at this line. In fact, this didn't happen. They went down, and they went right back up. This would be the natural course of Americans. The average American gains between a pound and a half a year from age 20 to age 60. So there's a continually upward curve in an individual from age 20 to age 60. So what we want to now do is partial normalization with risk factor reduction. So bring down the weight more modestly with the hope that we can sustain it over time. And as the weight comes down below 5% of baseline, we begin to see decrease in risk factors, particularly glucose and lipid factors and blood pressure. The trouble is that we're pretty good at getting the weight down 5 to 10%, but we're not good at sustaining it, and I'll come back to that. Maintenance of weight loss is the real problem we have around the world today. So we know that moderate weight loss will work. It will decrease glycemia, decrease hemoglobin A1C. It will improve hypertension. It will improve dyslipidemia, particularly lowering triglycerides and raising HDL is not so good at changing LDL. So our problem is that it's very hard, not so much to, as I said, to lose weight, but to maintain weight loss. The majority of overweight and obese people have attempted to lose weight and are always trying, or many of them are trying, although many have given up. In studies from NHANES, it suggests that a lot of people have tried to lose weight, and over half have tried to lose weight in the previous 12 months, but only 1/4 of those who tried to lose weight lost as much as 10 pounds. So it's something that people try to do with not much help, I should say, from their physicians usually, but have trouble doing well. You can see this in the look-ahead trial, of which we were a site. In blue, you have here the people who went through intensive behavioral intervention, and in red, the people who were unusual care, that is, they were just taken care of by their physicians, but they were given no intervention with regard to their obesity and with regard to goals for weight loss, et cetera. And you can see these are the people who actually gained weight, small number, but they did. But these are the people who lost greater than 5% of weight. I'm sorry, these are the people who lost a little bit of weight. These lost more than 5%. These lost more than 7%. These lost more than 10%. And clearly, people need help. You can see the difference between the red and the blue. And people in the red just were not able to, even though they were given lectures on wellness and health and getting out and exercising, et cetera, you really need help. And the people in blue had case managers who dealt with them, who talked to them once a week, who kept in touch with them, and who urged them forward and helped with knowledge. You can see that again here. This is another study we were a site. This is a diabetes prevention trial that went on in 26 sites around the country. Huge number of patients. This is the group that was the usual care group over a period of 48 months. This is the group that we set a goal of 7% from baseline, and these people on average at the start were 100 kilos, so they did lose 7% from baseline. And they maintained it for a year, but you can see after a year they began to creep up. They still maintain a difference from the usual care group of about 4 kilos, but they were not able to sustain this over time. This is a metformin group that lost about 2 kilos. And they were unable to maintain their weight, even though they really did increase their physical activity. This is the mets per hour per week in the intervention group, in the metformin group, and in the placebo group. These two did a little bit better, increased a little bit over time, but this group went up 6-fold and maintained that physical activity over the 4 years that the study continued. But even so, they were unable to sustain this weight loss over time. So success in maintaining weight loss is quite low. This is the Finnish diabetes study. After 1 year, only 43% maintained their weight loss. In the diabetes DPP, after 2.8 years, only 38% maintained their weight. In the hypertension study, after 3 years, only 13% maintained their weight. So what's going on here? You can see it here again in this rimonabant trial. Rimonabant was, as you may remember, a drug that was touted for weight loss, but was never approved because of suicidal ideation in people who took it. But you can see here they got a very nice weight loss over here for the first year. At this point, they re-randomized, put these people on placebo, and kept these people on drug. The drug maintained the weight loss pretty well. Look what happened to the placebo group. Look at that. They came back exactly back to the line of the placebo group on top. So what does that tell you? It tells you that if you have a drug that's working, you don't stop it. If you stop it, you go back, okay? It's the same way as you have a drug for high blood pressure. If it works and your blood pressure comes down, you're not going to stop the drug. You're going to continue the drug. If you have a diabetic drug that is working and it's dropping the glucose, you're not going to stop it. you're going to continue it. Well, you have to do the same with a weight loss drug. One of the reasons you regain weight is shown in this slide, and this is from my colleague Rudy Leibel at Columbia, and it shows you weight-stable obese individuals. Here studied after a 10% weight loss, here studied after a 20% weight loss. And this shows you their energy expenditure. This is the resting energy expenditure. This is the non-resting energy expenditure. And what you see is that the energy expenditure goes down. And so this works against an individual. As soon as they start losing weight, their metabolic rate goes down. They need less energy to do the same activities. So as a result, there's an inexorable kind of move back upwards, because for the same amount of weight, of food intake, they get much more for their buck. This is the breakdown of the energy expenditure in a sedentary person and a physically active person. This is a study we did some years ago with Karen Siegel, who was then a postdoc in my laboratory. You can see here in a sedentary person expending about 1,800 kcals a day, this is the resting metabolic rate, the thermic effect of food, and energy expenditure of physical activity. So in a sedentary person, you're getting somewhere around 15% of your energy expenditure for physical activity. You take quite a physically active person, and to go from 1,800 calories to 2,200 calories takes quite a lot of physical exercise. You can see you can increase your energy expenditure to 32%, and that will give you a lot of expenditure that will be good in maintaining your weight loss. This shows you the physical activity people from the weight registry. Weight registry is a registry started by Rena Wing and Jim Hill at the University of Colorado, and it follows people who have kept at least 60 pounds off for 5 years. And you can see what they're doing. They're doing a lot of walking, a lot of heavy activity, that is mostly jogging and aerobics. They're doing heavy activity, medium activity, a lot of stair walking, and a lot of light activity. So they spend a lot of time on exercise. And so their expenditure is extremely high, which allows them to maintain their weight. So what are the dietary factors that you have to worry about as you're seeing a patient who is overweight and you're trying to advise them to lose weight and maintain the weight loss? Well, you have to talk about a lot of things. You have to talk about nutrient composition. We'll come back to that. Energy density, which is very high in the US. Americans eat 18% of their calories as sugar, and 32% of their calories as fat. Incredibly energy dense food. Portion sizes are huge. Liquid calories seem to be recognized much less well than solid calories. Americans eat a lot of snacks that are high density snacks, and they do very little physical activity. So all of these need to be touched on as you deal with a patient who's trying to lose weight. Now, a lot of diets have been tried, and what you see here is a balanced diet. Protein, 15%, fat, about 30%, carbohydrate, about 55%. This is a high-fat diet, which is touted by a lot of people, where you really cut back the carbohydrates. This is a high-fat and high-protein diet, where you increase the protein to 30%. And this is a high-carbohydrate diet, more like the Ornish diet, where you have very little fat and a lot of carbohydrate. Now, which diet is good for a patient? Well, they're all good. I mean, they're all okay as long as the patient sticks to them. So you can work with your patients to see which one would be more likable to that patient, more likely that the patient will stick on that diet and will continue on it over time, because the problem is not the diet macronutrient composition. The problem is adherence to the calories, okay? So all this huge argument is, should it be high fat, should it be high carbohydrate? It can be either. You know, it's like a Volkswagen car that can run on alcohol and can run on gasoline. And the car decides which fuel to use according to the molecular weight of that level of that fuel in the car. And we do the same thing. If we have a high carbohydrate meal, we'll oxidize the carbohydrate. If we have a high fat meal, we'll oxidize the fat. But there have been quite a lot of studies to suggest that ad libitum diets that are low in fat tend to do a little better, and this is the change in ingestion with diets low in fat. This is an article, a review article published by Arne Astrup from Denmark a few years ago, suggesting that you can lower the number of calories if you have a low fat diet. So most nutritionists would recommend a lower fat diet rather than a low carbohydrate diet. And you can see the same thing here. You can see the change of fat in the diet going down, changing it by 5%, 10%, 15%, 20%, a downward trend in terms of change of body weight. So there is a suggestion that you might be somewhat better off with a lower fat diet. But if your patient is particularly interested in having a lower fat carbohydrate, that's perfectly all right. So this is the recommended one by the clinical guidelines from the NIH and NHLBI, with a carbohydrate content of greater than 55, protein at 15%, and then saturated fat no more than 10% of total calories, polyunsaturated less than 10%, and monos less than 15%. And you can actually go up on monos and replace carbohydrates with more monos if you wish, because monos are really pretty good for you, and that might be a good thing to do. The trouble with monounsaturated fat, it's very calorically dense. You know, olive oil, avocados, nuts. These are things that are incredibly nutrient heavy, so you have to be very careful how many of these nuts you would give a patient for a snack. So what are the questions to address with your patient to prevent weight gain? You have to work with them to decide the macronutrient composition of their diet. You need to talk to them about energy-dense foods, which are a huge problem in the United States. Huge problem with portion size, particularly when people go out to dinner. The effect of added sugars, particularly sucrose sweetened beverages, which seem to not be compensated for very well. The effect of solid fats, the effect of snacks, and then just discuss with the patient what particular intake pattern might be best to prevent weight gain in these people. So, what do we have here? We have the fact that the body, all our bodies, is pretty accurate at keeping a weight in a homeostatic pattern. If you take an energy intake in 1 year, it's about 1 million calories. Gaining 1 pound would take about 4,000 calories. So we're talking, if you're gaining 1 pound a year, which most Americans are doing, it's an area of about 0.4% or 11 calories a day. You know, it's not a lot. Who can count 11 calories? So This is why the idea of pharmacotherapy grew up. Because if the error is so small, why can't we find a drug that would be able to improve that situation? So I'm going to go through some of the drugs that are available to you now in the United States that you could use with patients. The first one is Phentermine. What does Phentermine do? It increases norepinephrine in the synaptic cleft. So this is a norepinephrine-like drug. What is its biggest downside? It does cause quite a bit of insomnia. So if you already have an obese patient who already has sleep apnea and has trouble sleeping, this is not a good drug for you. This is the only good randomized clinical study ever done with Phentermine. It was done in Scotland by Dr. Monroe, and it went out 36 weeks. The reason there aren't any more studies is when Phentermine came out, the FDA only approved drugs for 3 months. So nobody went beyond 12 weeks in any randomized trials because the FDA didn't want them to go out beyond 12 weeks. They thought you should only take a weight loss drug for 12 weeks and then stop. And of course, when they stopped, the weight went right back up. But this study is interesting, number one, because they did get, in a randomized controlled study, a loss of 12.5 kilograms from baseline. And again, they started at about 100 kilograms. The other interesting thing about this study is that they alternated. The red line is giving the drug on 1 month, and then off 1 month, on 1 month, off 1 month, on, off, and you can see the lines are superimposable. So by alternating every other month, they did just as well as the people who took it every day. So suggesting there was a sustained effect of this drug over time. This drug is the most heavily used drug in the US today. Why? Because it's cheap, it's generic. It costs a lot less money than the new drugs, which are still under patent. The second drug is Orlistat, works very differently. What it does is it blocks pancreatic lipase in the gut. As a result, what happens is when you take in triglycerides, and most of the fat you take in, as you know, is triglycerides. Very little of anything else, a little bit of phospholipids, a little bit of cholesterol, but most of the fat is triglycerides. It needs to be broken down into fatty acids or monoglycerides to be absorbed into the gut cell and transferred to the lymph. With pancreatic lipase, you can't break down the triglyceride, so you can't break down to free fatty acids, so you don't absorb it. It goes out in the stool. You get steatorrhea, you lose calories, and you lose weight. This is a typical trial done in actually primary care physician offices. You see that there's a loss of about 7.9% from baseline. 2 new drugs have been recently approved. The first is lorcaserin, which the drug name is Belvic. It's a selective agonist of the serotonin 2C receptor. The 2C receptor affects appetite and weight modulation. There's also serotonin 2B receptor that is present on cardiac heart valves, and it's because of this that the fen-phen combination, fenfluramine, caused heart valve lesions and had to be withdrawn from the market because it was not focused on 2C but also hit 2B, and you got heart valve abnormalities. The drug has been tested in phase 3 trials by the Bloom trial, the Blossom trial, and the Bloom diabetes mellitus trials. One was 2 years, the other 2 were 1 year. Wide range of patients, wide range of weight, a lot of patients, and the net effect is this. This is right here. You see the mean weight loss of 5.8 kilograms as versus placebo, and this shows you the completers analysis. This is last observation carried forward. This is completers analysis of 7.9 kilograms as compared to placebo of 3.7. This shows you again that if you re-randomized, and this is the weight loss in the first year, you re-randomize, this is the placebo group going right back up to the placebo group here, and this is the continued weight. Disappointingly, even continuing the weight in this group, the drug in this group, you get an increase in weight, regain in weight over time. This shows you the percent who lost 5% from baseline, 10% from baseline, placebo versus drug, and this shows you, this is the last observation carried forward, which really is the one you should look at. This is the completers analysis, which obviously always does better. So the next group is the this is the Phentermine and topiramate drug, and you can see that they did get a better weight loss of about 12 kilos from baseline over a period of a year. They have two doses, 15 milligrams of Phentermine, 92 milligrams of topiramate are the ones that are commonly used, and but one can stop at 7.5 and 46, which is this line here, as compared to this line here. You have to remember that this drug cannot be used in pregnancy, so you can't really use it in young women who are of reproductive age unless you're pretty assured that they're using contraception or they're not sexually active. So finally, just to mention that you can't just put a patient on a drug and forget him, okay? And say, I'll see you a year from now. Because what you get is this kind of a curve. What you need to do is really need to work with them in terms of lifestyle change, and hopefully you could even help them with their menu plans and their meal replacements and so forth. The more you do, the more intervention you do with the patient, the more likely it is that the patient will go down further and stay down longer. Okay? So just giving a drug and forgetting about the patient is not going to work. And finally, we know now that initial weight loss predicts long-term success. So if you get a patient and in the first first month they do very poorly, and certainly in the first 3 or 6 months, they're not going to make it. So you want to monitor people in the first 3 months, see how they're doing. If they're really not getting any impact from the drug, then I think you should stop the drug and not try to use a drug that really isn't working for them. And finally, the new kid on the block is what you heard early this morning, surgery. And surgery is interesting. When the doctor tells you that they lose 70%, he's talking not about total weight, he's talking about excess weight. So don't go home thinking people are going to lose 70% of their weight. That just isn't true. The lap band people in the SOS trial lost about 17% of their weight. The gastric bypass patients lost somewhere around 27% of their weight. But it is an operation that for some people is extremely helpful, and particularly people who are quite fat and have diabetes. Thank you very much for your attention.